Greetings, Patho students, and welcome to week 4. I haven't, actually I'm recording this before most of you have taken your first exam, so let me just say this. I haven't seen any of the results, but if you're happy with the results you got on that exam 1, then my advice to you would be to continue in your current manner of studying and prioritizing this class. If you are not as happy as you hoped to be with your results, my advice would be to hit that Prep U tab on your course. If you have not been doing it at all, start doing it. If you've been doing it just a little bit, do it a little bit more. This is where you're creating quizzes for yourself based on the chapter. So you go to Prep U and you say, I want to take a quiz on chapter 11, for instance, or chapter 12, or chapter 13. And it's going to randomly issue questions for you, and then the more questions you answer, the more information it has about identifying your strengths and weaknesses, so it can personalize the program a little bit for you. I will tell you that of the levels of questions that I gave you in this first exam, there's level 1, which is simply remembering, do you know? And level 2 is understanding, being able to understand a concept and answer appropriately. Level 3 is applied. Level 4 is analyzed information. So I want to say only 30% of the questions I gave you were at that level 3 and 4. So if you did not do well, I'm going to say that most of your questions, like I say, were at that level 1 and level 2 difficulty level. So the only way you're going to improve that is through practice. So you need to go in and start exposing yourself to that question bank and take time to read the rationales for each answer. And the program does a really good job of taking you back to the exact page in your book where you can find the answer, and then also tying it into NCLEX testing priorities. And if any of you have any specific concerns, you can, of course, email me. I'll be happy to talk with you. Week 4, we're going to be looking at chapters 11, 12, and 13 related to hematopoietic function, which is basically how our bone marrow makes blood cells. And also we'll start on chapters 14, 15, and 16, introducing infection and immunity, which is our introduction into one part of our body's immune system. So a little review on chapter 11, which is disorders of white blood cells and lymphoid tissues. There's a great diagram, it's figure 11-1 in your book, that basically is how do all these cells get made, and reminds you that they all start from one cell, one stem cell in the bone marrow that is referred to as pluripotent. Pluripotent. This is the stem cell that can become any cell, and you'll see the diagram demonstrates that. It has the ability to become white, red, NK killer cells, or whatever. Every one of those pluripotent stem cells has the ability to become any of those cells. Pretty awesome, actually. I want you to be able to differentiate the non-neoplastic disorders of white blood cells. Non-neoplastic, you should know this by now, meaning non-cancerous disorders of the white blood cells. You should know the definition and how we use the following terms, because we use these in clinical settings all the time. One is leukopenia. Leukopenia. Whenever you hear the word penia at the end, that is insufficient. Leukopenia, insufficient. Leuko, white blood cells. Leukopenia. Agranulocytosis. Whenever you hear the word cytosis at the end, typically that is an overproduction of, and in this case it would be of the agranulocytes, the agranulocyte type of white blood cells. And your book tells you the differentiation between the granulocyte white blood cells and the agranulocyte. I want you to know what that term is. But remember I gave you the mnemonic, never let monkeys eat bananas? That does not differentiate the agranulocytes from the granulocyte white blood cells. It just simply gives you the white blood cells, the 5 different kinds of white blood cells in the order that they appear as a composition of all your white blood cells. From the highest concentration being the neutrophils, N for never, neutrophils, down to B, banana, basophils, the lowest concentration. And your book does a good job of explaining the difference between all those different kinds of white blood cells. I also want you to know about aplastic anemia. Aplastic anemia. And the last term I want you to know is neutropenia. Remember, it ends in penia. Insufficient neutrophils, specifically neutrophils. So first we were talking about insufficient white blood cells. Now we're talking about insufficient neutrophils, the most abundant of all of our white blood cells, the neutrophils. I would like you to have a passing knowledge of the different kinds of leukemia. There are basically 4 classifications of leukemia. There are 2 that are acute. There are 2 that are chronic. There's acute lymphocytic, acute myelogenous, chronic lymphocytic, chronic myelogenous. I don't need you to differentiate the difference between all that. Know that these are 4 different kinds of leukemia. What I'd rather have you know is what are the complications of leukemia, period, regardless of the type. What are the nursing considerations for caring for a patient with leukemia? What is that patient at risk for? Jumping way ahead, if a patient dies of leukemia, they're going to die of infection or they're going to die of bleeding. So I want you to understand from your reading how that would happen. Also related to leukemia, a complication known as leukostasis. So again, use your medical terminology. As I say, leukocytes, white blood cells, stasis. So leukostasis is actually a complication that occurs from an overabundance of white blood cells where they clot together and simply clog up the circulation, and it can be quite serious. So that's one complication of leukemia that I want you to know about. Also, overview the malignant lymphomas, specifically Hodgkin's disease, Hodgkin's lymphoma, and non-Hodgkin's lymphoma. Instead of in the blood vessels with the blood types, this would be on the lymphoid tissue or the lymph system, the cells that circulate in the lymph system. So just know you're going to read about Hodgkin's and non-Hodgkin's. You should come away with the idea that if you have to have one, get Hodgkin's. That's the one to have, because Hodgkin's disease is a fast-growing disorder. The cells grow quickly, and fast-growing cells respond to chemotherapy much better. The non-Hodgkin's is a slower growing, and although today in 2018 there's much progress being made related to non-Hodgkin's as well. But I want to say 20 years ago, prognosis for a non-Hodgkin's lymphoma patient was not so good. Hodgkin's remains over 95% curable if it's diagnosed in the early stage, as in many cancers. And then lastly in this chapter, look at the plasma cell dyscrasias, the plasma cell disorders, specifically multiple myeloma. So if you go back to that very first diagram that shows all the different things, all the different kinds of cells that first stem cell can become, one of them is a simple plasma cell. The plasma cell, you'd think, doesn't really have that much to do other than float around and move agents around in the bloodstream, but multiple myeloma can also be deadly, very hard to treat, usually requires a stem cell transplant. So take a look at that for chapter 11. Moving on to chapter 12, disorders of hemostasis. Hemo, meaning blood, stasis, let's call it blood clotting, disorders of blood clotting. So know this before you head into the chapter, that our body is always clotting and lysing clots, clotting and breaking down clots all the time, normally. That's just part of our normal function. Any little thing you bump up against can cause a micro reaction that causes some tiny, tiny blood clots to form. But our system is also breaking them down. So these disorders have to do typically with platelets in some way, shape, or form. So I want you to read about the function of platelets. And then also focus on this, because I've mentioned this before when we talked about inflammation. Differentiate the roles of the epithelial cells. So the epithelial cells are those cells that line your vessels. The epithelial cells differentiate the roles when it comes to preventing coagulation, when it comes to promoting coagulation. So they have, those epithelial cells are pretty brilliant, and they have a dual function in both preventing and in promoting coagulation. So read about how exactly they figure out how to do that. As far as the clotting cascade, I'm not going to hold you to knowing the clotting cascade. I want you to look at it and appreciate the complexity of the clotting cascade and all the different features that must all align in order for our blood to clot properly. I want you to know what some of our diagnostics are that were used. We use typically every day, some of them in a typical blood panel, some of them for patients that have disorders. One is the prothrombin time. We refer to that as PT, the PT time. What is prothrombin time and why do we use it? And also the partial thromboplastin time. So we call that the PTT. Sometimes you'll see it referred to as the APTT, which simply is the word activated in front of it. So it would be activated partial thromboplastin time, the APTT. What is it and why do we use that? I want you to be able to define the role of clot dissolution or lysis in the process of hemostasis. So when we want a clot to form, good, it forms. If we want it to stay there forever, no, we want it to lyse. We want it to lyse according to this clotting, breaking down clots, clotting, breaking down clots that I referred to. Differentiate increased platelet function from increased clotting activity. Aspirin and Plavix. So we say that both of those medications who are given to cardiac patients, very often following a cardiac cath where they've had a stent put into one of their major coronary vessels. Because that stent is a foreign object, it's really important that the platelets don't get too curious about it. So what happens as blood flows through that newly opened coronary artery that's all excited to be getting perfused, carrying blood and oxygen to the part of the heart that it serves, that platelets don't stop around and say, what's this? It wasn't here last time I passed through. Let's stick around here and see what's happening. We give aspirin and Plavix. Those both have an antiplatelet effect. And I need you to know that that does not mean that the production of platelets is reduced. The aspirin and Plavix have no effect on the production of the actual platelet cells, but they do have, those drugs do have an effect on the abilities and the capabilities of the platelet. I tell patients that the Plavix makes their blood a little more slickery. It's just a word I made up, but it means that the blood's going to flow through this new artery more smoothly, and it reduces the risk of a blood clot forming right around this newly installed stent. Take a look at the clot dissolution and lysis, and then the platelet function when it comes to increased clotting activity. Another term for you, the causes and consequences of thrombocytosis. Let's break it down. Thrombocytes are platelets. Cytosis, remember cytosis I said just 5 minutes ago, typically means an abundance of or an overproduction of. So when you have a disorder that causes overproduction of platelets, what's that patient at risk for? I believe it's kind of logical that patient is going to be at risk for increased clotting. So what does that disorder look like and what can we do for that patient? On the flip side, the term thrombocytopenia, penia at the end, thromboplatelets, thrombocytopenia, insufficient platelets. And we have a number of disorders. Look at figure 12-4. We have a number of disorders that can result in thrombocytopenia. Sometimes medications, heparin for instance, a patient can have a reaction to heparin and develop heparin-induced thrombocytopenia. When that happens, we turn off the heparin, we put the patient on an equivalent, but not heparin, and we forever tell that patient to record, we record in the chart that he's allergic, he or she is allergic to heparin. Not a true allergic reaction, but might as well be. We never want that patient to have heparin again because of what it's just induced in the patient. You should be able to differentiate between inherited and acquired coagulation disorders. And I want you to know the role of vitamin K. Explain the sources of vitamin K and the functions of vitamin K in the clotting process. This is something that will come into, again, crossing over into pharmacology when a patient goes on the medication Coumadin. Related to patient teaching, we ask them to limit their intake of vitamin K containing foods. And you'll see in the clotting cascade the role of vitamin K. And then lastly, the most deadly of all clotting disorders is DIC, disseminating intravascular coagulation. This is a situation that if it's not corrected, the patient can and will die. And I've seen this myself in critical care units. DIC is when all of the patient's clotting factors have been used up. So there are multiple microclots circulating through the system, and they're all used up, so there's no way to stop the bleeding. So this patient presents clinically bleeding from every orifice, basically. Bleeding blood into the Foley catheter, bleeding from their fingernails, their mouth, their ears, their nose. And the treatment for DIC requires multiple of intensivists who hopefully have experience with this, and the patient's going to be getting both heparin, which is it's not a thrombolytic, but it's an anticoagulant, as well as clotting factors. In many cases, we give FFP, fresh frozen plasma, which has all the clotting factors in it. So they're getting both. They're getting clotting factors because they need them because they've used them all up, but they also need an anticoagulant to keep all those clotting factors from forming more clots. Then moving on to last chapter 13, which is disorders of red blood cells. So here's where you're going to read about the anemias, basically. Disorders of red blood cells, also known as erythrocytes. Same thing. I want you to read about the function of hemoglobin. You know that hemoglobin is carried on the red blood cell. And relate the blood oxygen levels. So do enough reading to do this. Look at figure 13.5. Relate blood oxygen levels to the process of erythropoiesis. So I think we've used this term before, erythropoiesis. Basically, erythrocytes, red blood cells, poiesis, making of. So what is it that stimulates the bone marrow to manufacture more red blood cells? One answer is erythropoietin, which is a hormone that comes from the kidneys that speaks to the bone marrow to say we need more red blood cells. And what causes the kidneys to produce that hormone? In some cases, it's hypotension or a lack of blood, and in some cases, it can be blood oxygen levels, low blood oxygen levels. So think of someone who moves from Arizona, which is at sea level, to Colorado, into a city that's maybe at 7,000 feet above sea level. We know that that person, not necessarily a patient, is going to have a period of acclimation and be short of breath. And their blood oxygen levels might be lower than they were in Arizona until this erythropoiesis effect kicks in, and that person will simply start making more red blood cells to help acclimate them. That is why if a football team, for instance, is going to play the Super Bowl in Denver, they're going to try to get in a week early to give their bodies time to acclimate to the thin air and to hopefully develop some more red blood cells to help them be less fatigued and to have more oxygen carrying capability. I also want you to look at the lifespan of a red blood cell, and that's going to include the breakdown of a red blood cell, what happens to bilirubin, how is bilirubin excreted, what is the nature of jaundice, which is when there is an excess of bilirubin. I'd also like you to look at lab tests that we use to analyze our red blood cells, our concentration of red blood cells, the number of them, etc. Look at table 13-1 and look at lab tests and the normal values for red blood cells. And keep this in mind. I'm going to tell you some that you really don't need to know, and I'm speaking as a nurse. You should know the red blood cell count. What is the total red blood cell count? You should know the hemoglobin. You should know the hematocrit, but know this, that if you know the hemoglobin, you can calculate the hematocrit, because typically you'll find that the hemoglobin is 1/3 the hematocrit, or the hematocrit is times 3 the hemoglobin. So the hemoglobin is the hemoglobin measured in grams. So let's say it's 15. Then I can tell you if your hemoglobin is 15, your hematocrit, which is a percentage of hemoglobin, should be 45, which is 3 times 15. So take a look at that and see if that works out for you. What you don't need to know as a nurse, I believe, and I'm not going to test you on this stuff that I believe in many cases is inconsequential to your actual clinical practice. There's a whole bunch of things in a RBC count or in a CBC count that speak to the nature of hemoglobin. What is the weight of the hemoglobin? What is the shape of the hemoglobin? What is the volume of the hemoglobin? I just told you that you need to know what the hemoglobin and hematocrit is, but you do not need to know the mean corpuscle volume, the mean corpuscle hemoglobin concentration, the mean cell hemoglobin, etc. If you're a hematologist, you are going to be looking at that. But these are, I want to say, a little deeper dive into the nature of the red blood cell that nurses simply do not need to know. You should know, related to these lab results, how we use this to diagnose anemias. I'd like you to spend some time reading about anemia, differentiate the 3 main causes of anemia and the categories. Look at figure 13.8 for that. We already said our bone marrow is responsible for production of all of our blood cells, including our red blood cells. If I'm anemic, I have insufficient red blood cells. Either my bone marrow is underproducing red blood cells, or my bone marrow is fine, but I am losing blood some other way. Perhaps I have a GI bleed. My red blood cells are being produced sufficiently, but I am losing red blood cells through my GI tract, which leaves me anemic. Or I have a disorder that is destroying my red blood cells before their lifespan. Remember, I asked you to look at the lifespan of a red blood cell? So that is leaving me anemic because my red blood cells aren't living as long as they should because I have this other disorder going on. So it's usually going to be one of those 3 directions when we go to investigate the cause for anemia. So that last is an example of hemolytic anemia, where my red blood cells are being destroyed. You should read about sickle cell anemia. We don't see it very often, but every once in a while there's a test question about sickle cell anemia. And then iron deficiency anemia. What is the role of vitamin B12, folic acid in treating these deficient anemias? Then lastly, take a look at this disorder, polycythemia. So poly, too many, many or too many. Cythemia, basically it's too many red blood cells, polycythemia. What is the patient at risk for if they're overproducing? This would be an overproduction of red blood cells, polycythemia. So read about this disorder and how it manifests itself and what is our treatment for a patient with polycythemia. This is interesting. I think blood is very interesting, and how our body recognizes and compensates for too much, too little of it. And our chapters are 14, 15, and 16. 14 is the mechanisms of infectious disease. 15 is innate and adaptive immunity. And 16 is disorders of the immune system. And if you recall, get into your Wayback Machine and go back to week 2. Week 2 was the first week we actually had content. Remember, week 1 was just like a tech week where we got used to everything. So in week 2, we had information in chapter 3 about inflammation and the inflammatory response and fever. And I mentioned that for some reason this publisher separates inflammation out when they teach about cell and tissue function, where other publishers actually bring inflammation in as part of the immune system. And I think I predicted that we would come back and revisit inflammation in a few weeks when we're dealing with the rest of the immune system. That's where we are right now. So I want to show you a graphic that I like because I think it simplifies things a little bit. Basically, this is inflammation that we studied in week 2. The inflammatory response, you might remember I called it immunity for dummies. Think of inflammation as a natural, non-specific, the inflammatory, local inflammation or systemic inflammation. Most of us have the ability to initiate an inflammatory response to a pathogen or in some cases an injury. Backing up one step, we do refer to inflammation as the second line of defense. The first line of defense, of course, is our mechanical and physical barriers. That is your skin, your mucous membranes, and think of your respiratory tract as well as your GI tract. Those biochemical barriers that contain normal bacterial flora, for instance, that is part of our first line defense. Our second line defense being the inflammatory process. And then the third line defense that we're going to talk about this week are these two combined. This is combined, they are called the adaptive immunity system. Adaptive immunity system, meaning specific, where we say inflammatory process is non-specific. These two are specific. They are learned. These cells have memory. To be very specific, the cell-mediated portion of the immune system, the worker bees of the cell-mediated portion are the T cell lymphocytes, and the antibody-mediated immune system, the worker bees, are the B cell lymphocytes. So remember that this is specific, it is learned, it is a slower response, however, it is a longer acting response. Sometimes texts will refer to the antibody-mediated immune system as the humoral, Humoral, humoral immunity. So I hope that helped a little. I hope it didn't further confuse. But I'm going to tell you some specific terms that I want you to pull, at least out of chapter 14, which is the mechanisms of infectious disease. I want you to look at the terms of virulence, pathogen, and opportunistic pathogen. There is going to be an introduction in this chapter of lots of things that cause infection. I would like you to focus on bacteria and viruses because those are the main two that we deal with. There's some others. There's fungus, there's parasites, there's worms, there's other things. And there are agents that specifically address some of those other kinds of infections. But they are more rare, they're less common. And for our focuses, I'd like you to focus on bacteria and viruses. Also the terms endotoxins and exotoxins. Be able to differentiate between those. Those are actually produced by bacteria. Some are enzymes that work to damage the plasma membrane, and others are, some of the endotoxins actually activate the inflammatory response and end up producing fever. So read about endo and exotoxins. I'd like you to be able to differentiate signs and symptoms. In nursing, we say a sign is something that we assess, and a symptom is something that is reported to us by the patient. So one would be objective, one would be subjective, as reported to us by the patient. But look at this text definition of sign versus symptom. Also, there are vocab word endings that will help us understand if we come across disorders that we're not familiar with. If we understand the root and then the suffix of that word, it'll help us to understand. So look at itis, so it would be dash itis, like rhinitis, for instance. Emia, sepsis, the definition for sepsis, septicemia, and abscess. Also, familiarize yourself with the two criteria that we use in the diagnosis of infectious disease, and they are culture, when we do a culture, to help make that diagnosis, as well as serology. Serology, that's when we draw blood and we begin to look at the different components that we see in that blood sample. The terms bactericidal and bacteriostatic. So if you think of homicidal, suicidal, what do those have in common? The cidal suffix, kill. So bactericidal is an antibiotic, for instance, that has the ability to actually kill the pathogen, versus bacteriostatic. What does the word static mean to you? Or stasis, sluggish, stopping, stasis. Bacteriostasis will simply stop the growth, stop the replication, or stop the development of a pathogen. There's a table that shows differentiation between antibiotics, antiviral, and antifungal. And even if you didn't even look at that, common sense would tell you that an antibiotic might be effective against bacteria, an antiviral might be effective against antivirals and antifungal, etc., as well as antiparasitic, etc. But know that for those antivirals, there are some. The most common viral infections that have antiviral medications are the influenza, the common influenza, and upper respiratory. Know that there are far, far fewer antiviral medications. Viruses still represent a big challenge when it comes to the development of medication. How do we crack through that virus to stop its replication and to stop whatever damage it's doing? Chapter 15 is about this innate versus adaptive immunity. So the innate, remember, if you can remember, the word innate has N-A-T, natural. I think of it as your natural immunity, back to that inflammatory process. And the adaptive, which is the learned, the specific, the slower acting, the longer acting immunity. Here we'll read about the nature of the adaptive acquired immunity. And then they'll again differentiate between the humoral immunity, which is the antibody-mediated immunity, and the cell-mediated, which are both part of that adaptive immunity umbrella. Read about the role of natural killer cells, the B lymphocytes, the T lymphocytes, which again are involved in the adaptive immunity. The function of the lymph nodes and the spleen. So I'm skipping over a lot. I'm telling you what I'd like you to focus on. Read about the epithelial barriers. I think I've talked about the importance of the lining of the blood vessels, the epithelial lining. So read about those epithelial barriers. Again, in this chapter, they overview the role of the white blood cells and how proteins contribute to the innate immunity system as well. So this, we've talked about white blood cells before, but this will be another review of white blood cells, as they are very important in our body's defense systems. This more is concentrating on the adaptive immunity side. Read about the role of antigen presenting cells and lymphocytes in the adaptive immunity side. So there are some cells whose only job it is to present the pathogen to the lymphocytes in order for them to do their job. Look for examples of how you would differentiate active immunity from passive immunity. Again, my memory tool here is the two words that begin with A, active and acquired. Active immunity is acquired. My body has, through memory, has acquired the ability to develop an immunity to whatever it is, versus passive immunity, which is given to me or provided to me. In some cases, that is through vaccines. In some cases, for instance, that could be mother passing immunity to a newborn baby through birth and also through breastfeeding. This chapter does deal with the immunoglobulin class. Immunoglobulin class, I think of, I associate the word immunoglobulin with antibodies. That is what we call IgG, IgA, IgM, IgD, and IgE are the main ones that are related to our immune response. So when I talk about passive immunity, for instance, a patient who is suffering from leukemia, who is getting chemotherapy, who has had their immune system basically knocked out by chemotherapy agents, they may be a candidate to receive some passive immunity. In some cases, we transfuse into their veins antibodies, synthetically created antibodies called IgG. So we call it IV, intravenous IgG. And there's lots of precautions that go, of course, with these kinds of transfusions, much like there's precautions associated with blood transfusions. And because this is passive immunity, this is temporary immunity. This will get a patient through a short period of time to buy them some protection time until their own body hopefully starts to kick in and produce some of these substances. When an antigen is detected, there is basically a primary and a secondary response. And that primary response of the humoral immunity side, at least, that is largely dominated by the influx of IgM. And my memory tool for IgM is M, I say immediate. So if there's a high level of IgM when we look at the patient's blood work, we know they're in the process of fighting off currently some kind of infection, pathogen, invader. And then the secondary immune response that comes in the second wave is the IgG that I just talked about that we can give intravenously. My memory tool for IgG is G is gone. The threat is gone or past, and now this IgG is going to help create this memory function of the immunity system for any future encounters with that same pathogen. So I want you to look in this chapter before you leave it, look at the IgM, the IgG, and then also look at IgE because that's going to come into play in the following chapter. So that's about it for chapter 15. Chapter 16 is disorders of the immune response. And this chapter is dominated by a discussion of hypersensitivity. Hypersensitivity reaction. So I want you to read about that. It's classified into 4 different types, type 1, type 2, type 3, type 4. And if I mention anaphylaxis to you, you might think, ooh, anaphylaxis, that's where people's throat closes up. And here, let me show you a picture of the initiation of anaphylaxis. If you remember in the movie Hutch, where I think Will Smith ate seafood. And then this is him in the drugstore. He's trying to find some Benadryl. But this is, if he did not have any intervention, he probably should have had a shot of epi or cortisone as well. But the Benadryl seemed to do the trick for him. He was in the process of having a type 1 reaction. You see swelling and mucous membranes, the release of histamine. So you can imagine at the cellular level, those cellular membrane walls are all leaky and fluid is going everywhere. And his voice does get hoarse, so he's starting to feel it in his throat. And that can go on to cause laryngeal spasm, and that is how sometimes, without intervention, people can actually die of that. But that is a type 1 response, and anaphylaxis is actually the most severe type 1 hypersensitivity reaction there is. So I want you to look at the 4 different types of hypersensitivity reactions. And then know about the terms donor versus host, the terms autologous and allogenic. And we use those terms when it comes, when we're talking about organ transplants or in some even ACL grafts. It doesn't have to be an organ, it can be a piece of ligament, for instance. Is your doctor going to use a ligament from your own body, split it, and then cross it over to attach to the other bone for an ACL repair? Or are you going to get a cadaver graft, ligament from a cadaver? So know about the difference in those terms. And then there's a disorder called GVHD, which is graft versus host disorder. Graft versus host disorder that can occur with organ transplants, but it also can occur with blood transfusions. It's the most severe reaction you can have to a blood transfusion, where we refer to the blood as the graft or the new, and the host, of course, is the patient receiving that tissue or blood. Immune disorders are another part of the research world that comprises a great challenge to researchers to try to get to the bottom of it. However, HIV, this chapter also deals with HIV. I'm not going to put great emphasis on it other than you need to know the definition of HIV versus AIDS. And in layperson's terms, I say HIV is when you've been diagnosed as a carrier of this virus, the presence of this virus. But AIDS is you have this virus and now you've got an opportunistic infection. So there are a number of HIV, AIDS related opportunistic infections. Once you get one of those, now we no longer say you have HIV. You're still HIV positive, but you are diagnosed with AIDS. And that diagnosis never really goes away. However, today with antiretroviral drugs, people in our country at least can live fairly full lives. They might have their life expectancy shortened by 10 or 20 years, but that is nowhere near what was going on in, say, the 1980s, where the HIV diagnosis was basically a death sentence because we hadn't discovered these medications yet, and a way to control them, to help the immune system combat them to the point where people can lead relatively healthy lives. Take a look at chart 16-2 in this chapter, which overviews the initial warning signs of a primary immune disorder, which we should all know what those signs are because you'll be surprised at some of them as they present themselves. And then lastly in this chapter, I mentioned opportunistic infections associated with HIV and AIDS. I'd like you to know what some of those opportunistic infections are. There's a couple of malignancies specifically related to HIV, as well as a syndrome called wasting syndrome, a few metabolic disorders associated with HIV as well. So that's it for week 4. You've got 6 chapters, chapters 11 through 16. Very interesting reading, if you ask me, but you've got no other activities that are due this week. If you have any questions about content, please drop me an email.